Hello, my name is Van de Keyser. I'm a neuroradiologist working at Ghent University Hospital in Belgium, and welcome to part 2 of my video on imaging anatomy of neck spaces. In this video, I'm going to continue discussing the anatomy of neck spaces. I'm going to discuss each and every of the neck spaces discussed in the previous video in a bit more detail, and I'm also going to illustrate the anatomy with a lot of pathological examples. I'm going to start in the center of the neck. When you're watching this video, I am assuming you also watched part 1. If you haven't, I'd advise you to do so because it will help you understand what I'm going to show you now. So I'm going to start my discussion of neck spaces with the central neck spaces, and that would be the pharyngeal mucosal space and the suprahyoid neck and the visceral space and the infrahyoid neck. Remember, the pharyngeal mucosal space and the infrahyoid visceral space are continuous with one another, so the distinction between the two spaces is a bit arbitrary. So in the suprahyoid compartment, we talk of a pharyngeal mucosal space and the infrahyoid compartment of a visceral space. Now the terminology learns us a lot. In the suprahyoid space, we call it pharyngeal mucosal space. Why? Because it's basically the space containing the mucosal line structures of the naso and the oropharynx and the suprahyoid neck. And in the infrahyoid neck, it's quite similar, but it contains more than just components of the pharynx. It also contains other visceral neck structures such as the larynx and the trachea. And the infrahyoid neck, so here we see the pharyngeal mucosal space and the suprahyoid neck, and the infrahyoid neck also considered part of the visceral space or the strap muscles, which are also visible located here anteriorly of the thyroid cartilage on this MRI image. Now, surgeons, ENT surgeons, don't really like it when we talk about the pharyngeal mucosal space or the visceral space. They want us to be, anatomically speaking, a bit more specific. So let's draw the hyoid, or let's make a distinction between the supra and the infrahyoid neck at the level of the hyoid, and the suprahyoid neck belonging to the pharyngeal mucosal space, we have the nasopharynx and the oropharynx, and the infrahyoid neck, belonging to the so-called visceral space, we find the hypopharynx and the cervical esophagus, as well as the larynx and the trachea. What are other components of the pharyngeal mucosal space? Well, the pharyngeal mucosal space contains, as said, the mucosa of the naso and oropharynx, but located underneath that mucosa, we can also find the pharyngeal constrictor muscles, we can find minor salivary glands, and some lymphoid tissue. We can also find the virtual peritonsillar spaces, which, however, can become infected in patients with tonsillitis, and that's the place where we will find a peritonsillar abscess. So knowing that these structures are all located in the pharyngeal mucosal space also makes it more easy to know what kind of pathology we can encounter in the pharyngeal mucosal space. So, as said, the pharyngeal mucosal space contains the mucosa of the naso and oropharynx. So when it comes to tumors, what is the most frequent tumor in the pharyngeal mucosal space? The squamous cell carcinoma arising from the mucosa of the naso and oropharynx. Now, the pharyngeal mucosal space also contains lymphoid tissue, so it can be the seat of lymphomas, and it also contains minor salivary glands. So despite the fact that these tumors are a lot less frequent in the pharyngeal mucosal space compared to squamous cell carcinomas, you can also find, for instance, adenoid cystic carcinomas or mucoepidermoid carcinomas, which are tumors that originate from the minor salivary glands. We can also find infectious disease in the pharyngeal mucosal space. This here is a patient with a tonsillitis. Here we see the palatine tonsils, which are enlarged and have a striated appearance, which is quite typical for tonsillitis. In this patient, we see hypodense areas in the enlarged palatine tonsils. These we would call phlegmones. They don't look encapsulated yet, but these are areas of liquefaction, probably containing small areas of pus. And when these liquefied areas coalesce and are encircled by an enhancing capsule, we call them an abscess, which is, anatomically speaking, not located within the tonsils, but in the so-called peritonsillar space surrounding the tonsils. And we call abscesses in this region peritonsillar abscesses. Let's now talk about the visceral space. Its contents are well known. Belonging to the visceral space are the larynx, hypopharynx, trachea, and cervical esophagus, but also the thyroid gland and the parathyroids. So, when we have a tumor originating from one of these structures, it will be located in the visceral space. And here are some examples. This was a patient with a very large hypopharyngeal carcinoma that has also extended into the larynx, as you can see, but the tumor has primarily originated in the area of the hypopharynx. Also notice the presence of a lymph node metastasis on the right side of the neck. This is a PET-CT scan in a patient with a laryngeal carcinoma, and this is a patient with a large tumor originating from the right lobe. Here we see the normal left lobe of the thyroid gland. So this is a very large thyroid carcinoma. Let's move on to the parapharyngeal space. The parapharyngeal space is located laterally of the pharyngeal mucosal space, and as you can see here, we only have a parapharyngeal space in the suprahyoid neck. So we don't have a parapharyngeal space in the infrahyoid neck. The parapharyngeal space is a pyramidal-shaped, fat-filled space between the base of the skull and the hyoid bone, so it extends quite deeply in the suprahyoid neck. And you will also see, if you are studying on your own, that in some articles and handbooks, this space is called the pre-styloid parapharyngeal space. The carotid space in those books is then called the post-styloid parapharyngeal space. I don't use that terminology. I find it a bit confusing. When I'm talking about a parapharyngeal space, I'm strictly talking about what in other books is referred to as the pre-styloid parapharyngeal space. So parapharyngeal space for me, there's just one. So I don't make that distinction. I talk about a carotid space and a parapharyngeal space. Now, the parapharyngeal space, how can you find it on imaging? Well, it's basically quite easy because it's located centrally within the suprahyoid neck and it is fat-filled. So it will be very hypodense on CT images and it will be hyperintense on T1 weighted images. It has a bit of a triangular shape, as you can see here, and its most narrow point in the axial plane will be situated in the pterygoid fossa between the tendons of the medial pterygoid muscle and the tensor veli palatini. This is not so easy to recognize, but this here is the pterygoid. Here we have the insertion of the medial pterygoid located over here, and this very small tendinous structure over here is the tensor veli palatini. And this is the most narrow point of the parapharyngeal space. As said, the parapharyngeal space extends quite deeply into the suprahyoid neck. So if you look at these consecutive axial T1 weighted images, let's focus on the right parapharyngeal space and let's follow it all the way down. And we can see that it becomes a bit larger, but it's still present over here, still over here. And let's even look deeper. So here we are again. Let's look on the right side and it becomes smaller, but it's still present. We are now at the level of the palatine tonsils. It has become very small, very smaller still, and then we end up above the submandibular glands. So the parapharyngeal space extends all the way down in the suprahyoid neck to the level immediately above the submandibular gland, and basically there's an anatomical continuity between the submandibular space and the parapharyngeal space. And if you look at these images, you can now understand why. What are the contents of the parapharyngeal space? Well, mainly fat, which makes it easy to recognize. So it's an important reference point when it comes to head and neck anatomy. There are some vessels there, some branches of the external carotid artery, like the internal maxillary artery and the ascending pharyngeal artery, and also the pharyngeal venous plexus. There are some nerves there, like some branches of the mandibular nerve for the innervation of the tensor and levator veli tympani. No, that must be palatini muscles. My mistake. So that's the palatini muscles, and also some ectopic minor salivary gland remnants. Okay, because it contains mainly fat and very little other structures, primary lesions at the parapharyngeal space are rare. I'm showing you two examples, but I had to look deep and hard in our database to find them. These are two patients who had a lesion that primarily developed in the parapharyngeal space. This patient had a schwannoma, and remember that the parapharyngeal space contains some nerves, some branches of the mandibular nerve, so that's definitely possible. This patient had a pleomorphic adenoma, and remember that the parapharyngeal space contains some ectopic minor salivary gland remnants, so it is not abnormal that you could develop a minor salivary gland tumor like a pleomorphic adenoma in the parapharyngeal space. Now, all in all, tumors arising in the parapharyngeal space constitute less than 1% of head and neck neoplasias, so it's definitely very infrequent. When you find a tumor there, the majority will be benign, and pleomorphic adenoma is the most frequent tumor arising primarily in the parapharyngeal space. Now, here's another example of a tumor that originated primarily in the parapharyngeal space. How can we tell? How can we tell that this tumor developed primarily in the parapharyngeal space and not, let's say, in the deep lobe of the parotid gland or the carotid space? Well, let's look at the unenhanced T1 weighted images, which, in my opinion, are the most useful to recognize the location of a tumor in the parapharyngeal space. If we look at these images, and let's start with the axial image, we will see that all the surrounding spaces are displaced by the tumor, which means that the tumor must have arisen between these spaces. Let's take a closer look. We see here the pharyngeal mucosal space, which is a bit displaced medially. We see here the carotid space, which is a bit displaced posteriorly. The parotid gland is displaced laterally, posterolaterally, and the masticator space is displaced anteriorly. This means that a tumor must have arisen between these respective spaces, and what do we find there? The parapharyngeal space. Remember that the narrowest point of the parapharyngeal space and the axial plane is between the tendons of the medial pterygoid muscle and the tensor veli palatini. And we can actually recognize those on this coronal T1 weighted image. Here we have the tendon of the medial pterygoid, and here the tendon of the tensor veli palatini. And here in green, and here we have the lateral pterygoid. Admittedly, this is a lot easier to recognize if you can scroll through the images, and most of the times you don't really need to recognize them to be able to localize a tumor, but when in doubt, it can help to look for this splaying of these two tendons. These are the same images, but I magnified them a bit, and we see on this magnified axial T1 weighted image that the tumor is completely surrounded by T1 hyperintense fat and that all other neck spaces are displaced by the tumor. On this magnified coronal image, maybe it's easier to recognize the tendons of the medial pterygoid and the tensor veli palatini muscle and how they are splayed by the tumor who originated primarily in the parapharyngeal space. Also notice over here the pharyngeal mucosal space and the presence of a stripe of fatty tissue between the tumor and the pharyngeal mucosal space. Okay, Now, if primary parapharyngeal space lesions are so rare, why is this space so important? Well, just look at the rest of the neck spaces. Because the parapharyngeal space is basically located in the center of the suprahyoid neck between most of the other neck spaces. So, if you understand the parapharyngeal space, this will be key to localizing a large mass in the suprahyoid neck by analyzing the pattern of displacement of the parapharyngeal space. Let's look at, well, I was going to say an example, but let's look what happens if you have a tumor in the vicinity of the parapharyngeal space. This is the parapharyngeal space in yellow. Now imagine you have a tumor, so the parapharyngeal space is located posteromedially to the masticator space, anteromedially to the parotid space. It is located laterally of the pharyngeal mucosal space, anteriorly of the carotid space, and anterolaterally of the retropharyngeal and the perivertebral space. And what happens if you have a tumor in one of these spaces? It will displace the parapharyngeal space in the corresponding direction. This means if you have a tumor in the masticator space, the parapharyngeal space will be located posteromedially. It will be displaced anteromedially by a parotid gland tumor. It will be displaced laterally by a tumor in the pharyngeal mucosal space, anteriorly or anterolaterally by a tumor in the retropharyngeal or the perivertebral region, and anteriorly by a tumor in the carotid space. So why is the parapharyngeal space so important? Because it's basically at the crossroad of the neck spaces. Let's now examine lesions of the parotid space. Parotid space anatomy is not that difficult. The parotid space contains the parotid gland, so most pathology in the parotid space will originate from the parotid gland. Other noteworthy structures in the parotid space would be the facial nerve and also some vessels like the retromandibular vein and branches of the external carotid artery. When it comes to pathology, there are two main types, and this is basically true for all neck spaces. Pathology in the neck is mainly tumorous lesions or infectious inflammatory disease. So the parotid space can host a whole range of different tumors, but the most frequent one is no doubt pleomorphic adenoma, and this was a pleomorphic adenoma. These tumors are often high in signal on T2 weighted images, and this was a patient with a unilateral parotitis. When a parotitis, an infection or an inflammation of the parotid gland, is bilateral, you have to suspect some kind of autoimmune disease. If it's unilateral, it will be more likely infectious in nature. This presentation will not go into too much detail. The goal of this presentation is to provide a quick introduction to the main pathology of each neck space. Now, when dealing with a very large tumor, like here, it can be difficult to determine the exact point of origin of the tumor. Is this a tumor that originated in the parapharyngeal space? Is this a tumor that originated in the parotid space? Did it originate in the carotid space? How can we tell? Well, take a look at the styloid process. You see this bony structure over here? This is the styloid process. And we can see that the stylomandibular tunnel, which is basically the area filled with soft tissue between the mandibule and the styloid process, this tunnel is enlarged. It will enlarge if a process originates in the parotid gland. It will narrow when a process originates in the carotid space. The fact that this stylomandibular tunnel is enlarged in this patient is very suggestive of a primary origin of this tumor, which was a pleomorphic adenoma, has originated in the parotid gland. Let's move on to the next space, which is the masticator space. The masticator space contains the muscles of mastication. It contains some bony structures, namely parts of the mandibule, and it also contains the mandibular nerve, which, and some of its branches, including the inferior alveolar nerve. Let's examine the anatomy of the muscles of mastication in a bit more detail. Centrally here we see the mandibule, And then we see located laterally the muscle belly of the masseter. Oh, I should have looked that up, how to pronounce it. The masseter muscle, I'm going to call it. Then we have the medial pterygoid muscle and the lateral pterygoid muscle, and also belonging to the masticator space as the temporal muscle. So these are the 4 muscles of mastication, all belonging to the masticator space. And only one of those is responsible for opening the mouth, and that would be the lateral pterygoid muscle. 3 are responsible for closing the mouth, namely the medial pterygoid muscle, the masseter muscle, and the temporal muscle. These are the muscles of mastication on an axial T2-weighted MRI image. Here we see the lateral pterygoid muscle. This is the medial, which is located below the lateral, so we see it on a lower slice. Here we have the masseter muscle, and here we see part of the temporal muscle, but we don't see it lower in the masticator space. The masticator space also contains the mandibular nerve. This can sometimes you can see the nerve on an MRI image. It all depends a bit on the resolution of your images, slice thickness, and so on. But if you know to find the mandibular nerve, you first have to know where it should be expected. So how can you find it? Well, use Meckel's cave as a point of reference. Here you see some magnified T1 weighted images and a magnified T2 weighted image and the coronal plane, all showing you Meckel's cave. So it's located over here on the T1 weighted images with gadolinium and over here on the T2 weighted image. If you found Meckel's cave, the next thing you should do is scroll forwards through your images. And if we scroll forward over here, we see Meckel's cave becoming smaller until it disappears. And if we scroll a little bit more, we suddenly see this linear structure over here exiting Meckel's cave and entering the masticator space. And this is the mandibular nerve of the trigeminal nerve. So it's the mandibular branch of the trigeminal nerve. So try it out. Of course, you can't always easily see it. It all depends a bit on your slice thickness and so on, but just try it out. It's always fun to discover the mandibular nerve. Well, I'm easily amused, but okay. Then what kind of pathology can we encounter in the masticator space? Well, 3 main categories: tumors, infrequent, and because the masticator space mainly contains bone and muscles, these tumors will then be sarcomas, rhabdomyosarcomas, osteosarcomas, and so on. But as said, they are not that frequent. More frequent, or probably the most frequent type of pathology you will find in the masticator space will be infection. And this infection, or these infections, typically have an odontogenic origin. They are mainly caused by diseases of the mandibular molar tooth, some tooth abscesses that erupted and caused infection in the surrounding masticator space. So this is not that infrequent and probably the main source of masticator space pathology. And finally, we can also find vascular malformations. This was I don't remember exactly, I think it's a lymphangioma. No, it was a venous malformation located in the right masticator space. Then the buccal space, I'm going to go very shortly on that one because the buccal space or the buccinator space does not contain that much elements, mostly fat. Sometimes you can find an accessory parotid gland or an accessory lobe of the parotid gland there and some vessels and nerves. So there isn't much that can cause pathology. It's mostly involved secondarily in disease processes originating from the surrounding spaces. Here's one example I found. So it contains mostly fat, and here we see a large T1 hyperintense mass lesion, not enhancing, and with a low signal on fat-suppressed T1 weighted images with gadolinium. This clearly is a large lipoma. Let's move on to more interesting spaces. And I'm going to discuss spaces that are present in both the supra and infrahyoid part of the neck. I'm going to start with the carotid space. So the carotid space is a somewhat cylindrical shaped space that extends all the way from the skull base to the aortic arch. The carotid space can communicate with the intracranial compartment because, well, there are openings in it for the internal carotid artery and the jugular vein, namely the carotid canal and the jugular foramen, and also through the hypoglossal canal. It is surrounded by the carotid sheath, which receives contributions from all three facial layers in the neck, and it is sometimes referred to as the post-styloid parapharyngeal space. Because I find it a bit confusing, I call it always the carotid space, and the pre-styloid I always call the parapharyngeal space, but I already told you that. So the carotid space contains the internal carotid artery and the jugular vein, so it contains vessels. And what does it also contain? Well, several cranial nerves. It contains cranial nerves 9, 10, 11, and 12. So that would be the glossopharyngeal nerve, vagal nerve, accessory nerve, and the hypoglossal nerve. Sometimes it is said that it contains the sympathetic plexus, but that is not really the case. The sympathetic plexus is located medially of the carotid space and the retropharyngeal space. That is not that important now, so I put it between brackets. And it also contains the ansa cervicalis, which is basically a collection of nerves coming from the three upper cervical segments of the neck, but also somewhat less important for this presentation. Just remember that in the carotid space, we will find cranial nerves 9, 10, 11, and 12, and also some lymph nodes. Okay, so this also means that when it comes to pathology of the carotid space, well, we have vessels there, we have lymph nodes there, and we have cranial nerves there. So what could we all encounter in the carotid space? Neurogenic tumors, like glomus tumors or schwannomas, lymphadenopathy, self-evidently, and this here is a multi-space conglomerate of enlarged lymph nodes, and also vessel disease. And here I've shown you a very large aneurysm of the cervical segment of the right internal carotid artery. But this is just one of the types of vascular disease we can find in the carotid space. I'm going to focus on the tumorous lesions, more specifically the neurogenic tumors. So there are two main types of neurogenic tumors we can find in the carotid space, namely the glomus tumors or paragangliomas and the schwannomas. This is a patient with a carotid body tumor or paraganglioma. What are paragangliomas? Let's start with that. First of all, they are rare, they are benign, and they constitute about 0.5% of all head and neck neoplasms. So they are not frequent, but because they have very typical locations, and a very typical imaging appearance, they are often easy to diagnose and recognize. These tumors arise from paraganglia. That's why we call them paragangliomas, which are specialized neuroendocrine cells of the autonomic nervous system and which tend to be located at very specific places or locations where they can give rise to tumors. 30% of patients with paragangliomas will have a specific genetic mutation or disorder, like multiple endocrine neoplasia, neurofibromatosis type 1, or von Hippel-Lindau disease, just to mention some. And in patients with genetic paragangliomas, and 30% is a lot of them, so you will often find multiple tumors. So the disease is often multicentric. What are typical locations for paragangliomas? Because I said that paragangliomas tend to have very specific locations. Well, the most frequent location would be above the carotid bifurcation between the internal and the external carotid artery. Paragangliomas in this location are sometimes called carotid body tumors, and they constitute about 60 to 67% of paragangliomas in the head and neck region. Then we have tumors in the location of the middle ear. We call those tympanic paragangliomas. So these are located in the middle ear, and they arise from the Jacobson nerve, the inferior tympanic branch of the glossopharyngeal nerve. We can also have jugulotympanic paragangliomas, which are tumors located partially in the middle ear and partially at the jugular foramen, and these arise typically from the Arnold nerve, which is the mastoid branch of the vagus nerve. And then we can also have jugular paragangliomas, which are strictly located in the jugular foramen and do not extend in the middle ear. Then lastly, we have vagal paragangliomas, which are typically located posteriorly of the internal carotid artery at about 2 centimeters of the skull base. So they have a very typical appearance on imaging, so they have a very typical location, but they have a very typical appearance as well, because they are very vascular tumors, which will mean that they will enhance intensely following gadolinium administration, as you can see on this T1 weighted image with FATSAT after gadolinium. And because they are very vascular, they often contain a lot of flow voids, which give them a so-called pepper and salt appearance. So we can see all these very small black dots in the tumor on these two images. These are flow voids, and the resulting imaging appearance is sometimes referred to as the pepper and salt appearance. This is an example of a carotid body tumor discovered incidentally on a CT angiography of the neck. Here is this very small tumor. This is a CT angiography, but we already see enhancement of the tumor because it's very, very vascular. And if you look at the sagittal image, you will see that the tumor is located in the middle on top of the carotid bifurcation between the external carotid artery anteriorly and the internal carotid artery posteriorly. So, and this is a small tumor, but large tumors will really push these two vascular structures apart and cause splaying of the external and the internal carotid artery. And then the external will be pushed anteriorly and the internal will be pushed posteriorly. And the internal carotid artery will remain located in the vicinity of the inferior jugular vein, which is visible over here. This is an example of a vagal paraganglioma. So these are the least frequent of all the head and neck paragangliomas, but they have a very typical location. Here we have a glomus vagale or a vagal paraganglioma. And if you look at a sagittal image, we see that it's located not above the carotid bifurcation, but posteriorly of the internal carotid artery at about 2 centimeters below the skull base, which is the typical location for glomus vagales or vagal paragangliomas. We also see that the internal carotid artery is now pushed anteriorly. So it's not located behind the tumor as in carotid body tumors, but it is pushed anteriorly. Here we find some branches of the external carotid artery, and here we have the internal jugular vein. So the inferior carotid artery and the internal jugular vein are now displaced from one another, while in a carotid body tumor, they are still located next to each other. This is an example of a carotid body tumor, and here we have a vagal paraganglioma. In the carotid body tumor, we can find the internal carotid artery posteriorly of the tumor, while branches of the external carotid artery are located anteriorly. And the vagal paraganglioma, both the internal and the external carotid artery are located anteriorly of the tumor. Another type of tumor we can encounter in the carotid space would be a schwannoma. So the location is quite similar. So can we tell the difference based on imaging appearance? Well, luckily we can, because there are some striking differences. Here I'm showing you two tumors located in the carotid space. One is a glomus tumor, the other is a schwannoma. These are the T2 weighted images with FATSAT from both patients, magnified over the tumor, and these are the T1 weighted images with gadolinium and FATSAT, also magnified over both tumors. Well, this is without FATSAT, clearly. We see here a lot of flow voids, so this is a glomus tumor. Here in this tumor, we see that the tumor has a very high signal on T2 weighted images, somewhat inhomogeneous, and is intensely enhancing, but we can't find the salt and pepper appearance we see in the glomus tumor. So this is a schwannoma, and here is an arrow I don't know why I included that. So based on imaging appearances, yes, we can make the distinction. And this is a carotid space schwannoma. So what are schwannomas? We know them well from the world of neuroradiology. These are benign tumors arising from the Schwann cells. And in the carotid space, well, there are a lot of cranial nerves all surrounded by a myelin sheath that was formed by Schwann cells. So schwannomas in the carotid space can arise from the glossopharyngeal nerve, the vagal nerve, the accessory nerve, or the hypoglossal nerve. They most commonly originate from the vagal nerve in the carotid space, and a way to make a distinction with carotid body tumors or paragangliomas is the absence of flow voids. This is the same patient. So here we see a large tumor in the carotid space at the level of the oropharynx, which is not unimportant. It has a high signal on T2, somewhat inhomogeneous, but no flow voids. And on T1, it is almost homogeneously enhancing, not quite, but for the most part, also without flow voids or salt and pepper appearance. Now, can we tell which cranial nerve this tumor originated from? Well, first of all, should we? Is it that important? Well, yeah. As a radiologist, we always want to prove that we know our stuff, so we're going to give it a try. Then we have to talk about the anatomy of the carotid space in a bit more detail. So here we have the carotid space. I magnified it and made a drawing. And we see the various components of the carotid sheath. So as said, the carotid sheath is composed of the deep, middle, and superficial layers of the deep cervical fascia. So here is the deep component, this is the middle component, and here we have the superficial component, and these all contribute to the carotid sheath, and it contains the internal carotid artery and the jugular vein. The internal carotid is always located medially of the jugular vein in a normal situation, and then it contains cranial nerves. It contains the glossopharyngeal nerve, the vagal nerve, the accessory nerve, and the hypoglossal nerve. So this is at the level of the suprahyoid neck, and typically the vagus nerve is always located somewhat posteriorly between the internal carotid artery and the jugular vein. Also important, the vagal nerve is present both in the supra and the infrahyoid neck, while the hypoglossus, glossopharyngeal, and accessory nerve all exit the carotid sheath. They all pierce the carotid sheath pretty high up in the suprahyoid neck, already at the level of the nasopharynx. So the glossopharyngeal, accessory, and hypoglossal nerve are only present in the suprahyoid part of the neck when they pierce the sheath anteriorly, and the vagal nerve is present in both the supra and infrahyoid neck. Now, if you have a tumor that looks like a schwannoma at the level of the nasopharynx, it can theoretically arise from all cranial nerves, but if it arises from the hypoglossal nerve or the glossopharyngeal nerve, it will push the internal carotid artery posteriorly. If it arises from the vagal nerve or the accessory nerve, it will push the anterior cranial artery, internal carotid artery rather, anteriorly. Now let's look back at our patient. This tumor was located at the level of the oropharynx. It has a component that is mostly in the suprahyoid neck, but also in the infrahyoid neck. At this location, it can only be a vagal schwannoma because it is too deep for a schwannoma arising from the hypoglossus, glossopharyngeus, or accessory nerve. We also see that the internal carotid artery, shown here, is pushed anteriorly by the tumor, and we see some splaying between the internal carotid artery and the internal jugular vein. So this is what we expect from a vagal schwannoma, based on our knowledge of the anatomy. I'm going to end this presentation here because otherwise it's going to become way too long and I need a drink. I'm going to continue with the retropharyngeal space and the perivertebral space in a moment. Thank you for watching.